Bismillahirrahmanirrahim. Assalamu alaikum, dear students. I hope your Ramzan will be going good, and I hope that you and your families are fine and safe from this COVID-19. Now, look at this scenario and read it. A 45 years aged lady presented with sudden severe pain in upper abdomen, which radiates to the back, and she tries to get up and sit in the bed, but her attendants are constantly trying to keep her laying in the bed. Her pulse is 90 beats per minute, respiratory rate is 28 per minute, and abdominal examination, there's mild tenderness in the epigastric region. Now, questions are that what other features will you ask in history from this patient? What is your most probable diagnosis? And what are differential diagnoses? Justify each with an opinion that, with the point that why it's not most probable diagnosis. Like if you say that differential is also cholecystitis, so why in this scenario you will say that it's not my probable diagnosis. It is differential diagnosis, but it is not the most probable diagnosis. Similarly, other whatever differential diagnosis come into your mind, and give the 5 investigation with justification means that why you will advise something. Like if you say I will advise ultrasound, so why you will advise what you want to see in that ultrasound. So this is how you will face questions in your uh, theory exam, and even a patient will present in such a scenario in your OSCE or in your long case or short case. So this is case of acute pancreatitis. Now you all know by just name of this disease that it is inflammation of the pancreas. Now pancreas is an endocrine and exocrine glandular structures lying in the almost at the epigastric region. If you recall anatomy of the pancreas, it makes a bed of the stomach and is surrounded by the duodenum C-shaped form, and you can see that biliary channel passes through the head of pancreas and joins the pancreatic duct, and then it opens into the second part of the duodenum by the ampulla of water. Now it's an acute condition present with pain abdomen, as you have just went through that scenario. And there is, when you do biochemical investigation, there will be significant rise of serum amylase and lipase. And if you go for further investigation, like doing CT scans, so there will be characteristics finding of the um, pancreas. Like uh, there will be degeneration of the fatty tissue, there will be necrotic tissue formation, which we discuss later on. And this pain may last for weeks or even for days, depending upon severity. Now, there are two types of, pathologically, there are two types of pancreatitis: interstitial edematous pancreatitis and necrotizing pancreatitis. Edematous pancreatitis means that there will be inflammation, there will be, and you, if you recall all features of inflammation, dropper, dollar, there will be swelling, there will be edema. So, this is acute condition. And basically, it will present with mild acute pancreatitis, which is characterized by the pathological interstitial edema of the gland, and will be present with pain and vomiting and nausea, and majority of these patients have mild attack of, we'll call clinically it is mild acute pancreatitis. Pathologically it is interstitial edematous pancreatitis. Now its mortality is around 1%. Like it's mostly patients recover from it if it just remains to the edematous stage, but once it progresses to the necrotizing phase, then it's a very dangerous disease, and almost 20 to 50% mortality from this disease. And there is severe pain. In addition to pain, there is systemic inflammatory response and multi-organ failure. Now, how this pancreatitis occurs? If you recall functions of the pancreas from your physiology knowledge, so it secretes the proteolytic enzyme which assists in breakdown and which assists in digestion of the uh, proteinaceous food. So there is which enzyme it is? It is trypsin, chymotrypsin, which is converted into trypsin and then it digests the food. Now, when there is obstruction to the duct, when there is obstruction to the pancreatic or biliary duct, which is basically making the both are opening into ampulla of Vater. So when there is obstruction from any cause, what will happen? Hypersecretion of the exocrine enzymes of the pancreas. Now, when they secreted, there's a blockage, so they may go into the bile, or bile may come down, and it leads to activation and conversion to ectoform, and then that leads to digestion of the pancreas. Same thing that normally they are released in intestine, but when there are obstruction, so they will be activated and they will cause autodigestion of pancreas. What is autodigestion? इस घर को आग लग गई घर के चिराग से. It is a cascade of reaction, inflammation, necrosis, and digestion of vascular walls, and then thrombosis, DIC, and ultimately shock and multi-organ failure, and then death. There is a long list of causes. Uh, it may be gallstone. If you look at this diagram and you see this area has been zoomed here and you can see stone. So the most common cause of pancreatitis is gallstone. Second cause is alcoholism, and then there are other traumas like if patient was already having stones and CBD and ERC has been performed, so ERCP can also lead to trauma. Similarly, any abdominal trauma, because there is when there is a severe trauma, there is crushing of the duct of the biliary of the pancreatic duct, and that there then again leads to the same phenomena, obstruction and activation of the enzymes following biliary, upper GI, or cardiovascular surgeries. Now these very major surgeries may give rise to shock, and that shock also leads to pancreatitis. Ampullary tumor, same phenomena, obstruction. Now that some drugs have some, may have some reaction with the interaction with the enzyme activation. Then the hyperthyroidism, hypercalcemia, pancreatic divism, long list of these diseases. So these, when you take history, you should keep these precipitating factors or causes in your mind. But the most important cause or most common cause is gallstone. The same thing as we have already discussed. Now this uh, gallstone or obstruction again depends upon some anatomy of the ampulla of Vater. You see here in figure 8.1, both pancreatic duct and CBD are opening into a common channel which makes the ampulla of Vater. So if there is obstruction in this ampulla of Vater, so bile will go down or pancreatic fluid will go into the bile and into the bile, and both can lead ultimately to activation of the pancreatic enzyme. Or they even have a different course, but ultimately they have one single opening. Again, the same phenomena that there will be activation of these enzymes. Now, if there is their openings separately, then there is less chance of gallstone pancreatitis because there is no obstruction to that area. How it manifests, how it presents with the abdominal pain. It's a main symptom, and pain is located in the lower upper quadrant or mid-epigastric region, and commonly it radiates to the back. Why back? Because this pancreas is a retroperitoneal structure, so that may be the reason for that. Its sudden onset severe and it pierces into the back, and uh, patient tries to sit down and are leaning forward because it relieves the pain. It is the extra burden of the stomach and other organs which increases the pain. So when patients sit down, so there is the pressure over the pancreas is decreased, and patient feel a bit relieved. And when the patient lies down, the pain aggravates. Now you also look for other features, also ask for other features. What other features are? There may be nausea, there may be repeated vomiting, persistent retching, hiccup, and history of fever. One more thing which you ask in this history, that whether the patient has undergone some surgical procedures like ERCP or any cardiac surgery, which we have discussed in the causes of the pancreatitis. So this is how you will that it will address the first part of your question of scenario which I have given in the initial slides. Now, it's very easy to make a list of differential diagnosis in surgical scenarios, because you just imagine the anatomy of that area and make diseases from those organs. Like duodenum is lying there, so perforated peptic ulcer again will present pain like this. If there is acute cholecystitis, inflammation of the gallbladder, or there in um, any liver inflammation, hepatitis, or hepatic abscess. Similarly, myocardial infarction will present in epigastric, may present in epigastric regional pain, and lobar pneumonia or basal pneumonia, pleuritic pain will also present with the such like pains. But you will differentiate on your on other causes, like is this one part, another part of your that scenario is that what is it, your differential diagnosis, and justify or give you points that why you are not making them actual diagnosis or most probable diagnosis. Like perforated peptic ulcer, there will be history of peptic ulcer disease, and there is both are sudden onset pancreatitis and this as well. But the history of peptic ulcer disease will differentiate on only history basis. There are other investigation and examination. When you examine, there is very much rigidity at that there in the perforated peptic ulcer. While in case of pancreatitis, is the structure is lying retroperitoneally, so there will be severe pain. It is said that it is the pain is out of proportion as compared to examination findings. Like you will examine patient and there will be no significant tenderness, but patient will be in severe pain. While in perforated ulcer, peptic ulcer, abdomen will be rigid, board-like rigidity, and there will be sudden onset. So this is differentiating point that why you are not making perforated peptic ulcer is your most probable diagnosis in that scenario. Similarly, acute cholecystitis, again, the tenderness will be in the right hypochondrium, and there will be repeated history of that pain as well. And it's not usually of acute onset. It's usually present with some malaise, fever, body aches, and then there is tenderness localized to the right hypochondrial region. Myocardial infarction, how you differentiate from the that scenario, that there will be some cardiac history, a patient will be in shock, and when you examine their patient, BP will be low, blood pressure will be low, and there will be no tenderness. While in a case of acute pancreatitis, there will be mild tenderness in the region of epigastrium. And then you proceed to the, after taking proper detailed history, you proceed to examination of that patient. So you look for cyanosis. So in patient will be cyanosed because due to extra oxygen demand in that patient, the respiratory rate will, there will be tachypnea, there will be tachycardia, and there will be hypotension. Patient may or may not be jaundice depending upon the cause of that disease, or depending upon the size of stone. If there's complete blockage of the CBD, so their patient will be jaundice. But if there is stone in such a size that it allows some bile to pass through, so there will be jaundice may not be present. And initially, patient may not have any temperature, or patient may have mild pyrexia. And then, depending upon severity of the disease or progression of the disease, if it progressed from interstitial oedematous pancreatitis to the necrotizing pancreatitis, so they will be swinging in high grade fever then starts. We then proceed to systemic examination. As I told you that it is a retroperitoneal structure, so tenderness may not be as much marked as you expect from the symptom of that patient. And there may be distension. Why distension? Is the disease progress? So there is whenever there is inflammation, so there is sympathetic ileus at that area. So intestines movements starts to slowly become sluggish and stops. So it leads to ileus and ascites. Why ascites occurs? Because there is inflammation, and slowly that inflammation spreads systemically, and there is uh, um, edema and oozing of fluid into the abdominal cavity, and that leads to ascites. And then there are features of ascites. Then how you, when you examine, there will be shift in dullness. Now this thing we will teach you when you come to the clinical, inshallah. It's difficult to make you understand this in the oral presentation. Palpable mass maybe may or may not be present, because if there's edema of the pancreas, so it's possible that you feel some mass. But if there's not significant edema, then you will not be able to elicit mass on examination. There may be some tightness, muscle gardening, but not as rigid as it is in the peptic ulcer disease, perfected peptic ulcer disease. Bowel sound may be decreased, and on inspection you can see discoloration of this umbilical region. So there may be discoloration of the around the umbilicus, which is known as colon signs, and there may be discoloration at the both flanks, which is known as Great Turner sign. Now these signs are due to hemorrhages and due to spread of that inflammatory fluid in the planes of the abdominal wall, which collects at the umbilical region and into the flanks. And these signs then are one of the pathognomonic signs of the pancreatitis. Now, after taking this complete history and examination, then you proceed to investigation with some aims. And your aim is that whether your diagnosis of your clinical diagnosis of pancreatitis is correct or it is something else, because management changes with the change in diagnosis. And how severe the attack is, whether it is mild attack, moderate, or severe, that we find out on some investigations. And what is etiology? Because if etiology is the most common one, that is gallstone, then you can treat it. Now, gallstone means that there may be cholelithiasis, or some small stone may have passed down into the CBD, and that then it have led to the pancreatitis. So, if you remove that stone from the CBD by ERCP, so the problem will be solved. So, therefore, it is important to go for investigation to find out cause of acute pancreatitis. Now, serum amylase and serum lipase specifically, they will tell us that whether pancreatitis is present or not. If they are normals, and then you revise your diagnosis. The blood glucose, serum calcium, triglyceride, and complete blood count. These will help us and to know the extent of that disease, whether it is mild, moderate, and severe. Now, the if there is short history, like patient comes to you in the OPD that I have just for the last 12 hours or 10 hours that pen has been started. So if you advise ultrasound at that time, in addition to those lab investigation, so ultrasound, do not expect that ultrasound will tell you about the edema of the pancreas at that time. But the important thing that it will tell you whether there is any stone in the CBD or if there is any cholelithiasis. So your diagnosis will be established to some extent, that it may be if there is the lipase and amylase are raised, and there is ultrasound. On ultrasound, there are stone in CPD or gallbladder, so it means that it is gallstone pancreatitis. Now, why look for gallbladder bile duct diameter? Usually, it is around it is less than 1 centimeter usually, or you can say even less than 5 mm routinely. But if there is pancreatitis, if there is some obstruction to the either partial or complete obstruction to the lower end of CBD, which sometimes you will not be able to see stone. But if it is a dilated CBD around 1 centimeter or more than 1 centimeter, so it's mean that there is either some malignancy lower down, or there is some stone which causing dilatation, and the whole thing which we have just repeated, that we just said, that activation of the enzymes and leading to pancreatitis. Now, just at admission, if you perform CT scan, it will be used this, because CT will tell you about swell edema of the pancreas, or if there is some necrosis has been developed, abscess formation has occurred, then it will detect that thing. But within 24 hours, 72 hours, it's very unlikely to see these findings. So no benefit of doing CT scan initially. Now you can see this is a CT scan of a patient. This is some normal. This is all pancreatic tissue. You can see the change in the character of that pancreas. You can see this is normal looking, and this is like, so this is necrotic area of the pancreas. Now this is probably a gallbladder. Now next is ERCP. ERCP, as we have discussed in last lecture of about cholelithiasis, it's diagnostic as well as therapeutic. So it will help us to, if we have detected some stones on ultrasound, so it will remove those stones. Other investigation is if there is CBD dilatation, but there is no clear demarcation or clear evidence of stone. So if you then in that case proceed to ERCP, so that will be a damaging, or it may aggravate symptom of patient. So better if facilities available of MRCP, magnetic resonance cholangiopancreatography, it will show you that whether there is any stone present or not. If on MRCP there is stones, and then you can proceed with ERCP to remove those stones. And chest X-ray will show you any uh, pneumonia or any fluid accumulation in the chest cavity. Now, on best, as I told you, that you do some tests like blood glucose, calcium levels, urea creatinine. These all investigations you perform to find out extent of the disease, whether it is acute, moderately severe, or it is severe. Now, these prognostic scoring system are Ranson and Glasgow coma scale. These are performed at admission within 24 hours, then at 42 hours and 7 days. Now, if any score is more than 3, it indicates severe attack of pancreatitis. That's why it's important to know, because then you become more vigilant to manage that patient. Now, this is Ranson score, and that is Glasgow coma scale. Glasgow coma scale is done in 48 hours, and Ranson at admission. If and some criteria are similar in both, and there are some differences as well. So age, which we come to you, which we come to know in his taking history taking, and then the WBC count and blood glucose, LDH, AST, and then there are blood urea sugar, serum calcium level. Now, if it is more than normal values, should give you a score of 1. So if score of 3 or more, it means that patient is in severe pancreatitis and moving towards severity. Now again, there's some repetition of the symptoms. Mild acute, there will be no organ failure and no local or systemic complication. How you define mild pancreatitis? When there is patient having pancreatitis, lipase, amylase are raised, and there is some edema of the pancreas as well. But uh, urea, sugar, etc., they are normal, and there is no local or systemic complication. In moderate to severe acute pancreatitis, there will be evidence of organ failure, like if there is raised creatinine and urea, it means that uh, renal system is going towards failure. So there may be evidence of some organ failure, but when you perform tests after 48 hours, so there will be resolution of that. So that organ failure was developing, but it was controlled due to routine standardized treatment. And there may be some local or systemic complication like respiratory, cardiovascular complication, but there is no organ failure. Now, severe acute pancreatitis, when there is organ failure prolongs from more than 48 hours, either single organ failure or multi-organ failure. So then you label it severe acute pancreatitis. Now, why you label it whether it is acute, whether it is moderate or severe? Because then management plan and area of management changes. Like in acute pancreatitis, just give IV fluids, and frequent non-invasive observation like pulse, BP, and temperature record, in a brief period of null by mouth, that like you should not make patient NPO for a week. Just if patient feel nauseated or patient has done some vomiting, so better to not to give by orally if till the patient appetite improves and patient can take. Because if you give food uh, without patient wishes or desire or appetite, so it will lead to further vomiting and nausea. And antibiotics are not recommended in acute pancreatitis until there is evidence of infection. Evidence of infection is there is leukocytosis, if there are other markers are raised, like nowadays, our procalcitonin is a marker which we have just came to know in the COVID 19 pandemic, that it is done very frequently. If there are procalcitonin is raised, it means that patient needs antibiotic. There is evidence of infection. Otherwise, giving prescribing antibiotic in to each and every patient are not desirable and are not recommended. It's very important to relieve patient pain with analgesics and antiemetics if there is nausea or vomiting. And you will perform CT scanning. CT scan if the symptom persists, if fever persists, and there is evidence of patient deterioration. If these vital markers are deteriorating, then you will go for CT scanning. Now, once your diagnosis is based on investigations and assessment, clinical assessment, it is severe acute pancreatitis, then you admit that patient into a high dependency unit or in intensive care unit and provide adequate analgesic relief, analgesia to relieve of for the relief of pain, and aggressive fluid rehydration, because if patient is in shock, you have to replenish that fluid. If look for oxygen saturation, and if required, you will use supplementary oxygen. And this is the all list of monitoring of patient, frequent monitoring, and NG nasogastric drainage, because uh, when there is severe inflammation, so there may be gastroparesis, distension of the abdomen, and risk of vomiting. So better to keep it empty for some time, 1 or 2 days. If there is any evidence of infection like cholangitis, then you can do and give antibiotic, or any other evidence like you perform CT scan and there is necrosis or the abscess formation, so you will proceed with the antibiotic. So this was all about clinical presentation, and then differential diagnosis, investigation and classification on basis of investigation and history, and then you do treatment. So this is all about today's lecture. Next time, inshallah, we'll discuss complication of acute pancreatitis and other surgical management for that. So thank you very much. Allah Hafiz.